Student, good day. And topic our lectures today, anesthesia. Anesthesia have a long time history, and attempts at producing a state of general anesthesia can be traced throughout recorded history in the writing of these ancient Sumerians, Babylonians, Assyrians, Egyptians, Indians, and Chins. Soon at the first, I tell you about the older sojourn, Chin's sojourn, how Tao. Years of your life from the 145 to 220 years. How Tao was a Chin's sojourn of a 2nd century AD. According to the records of three kingdoms and the book of the late Han, and how Tao performed surgery under general anesthesia using a formula he had developed by mixing wine with a mixture of herbal extracts he called mafezin. How Tao reportedly used mafezin to perform even major operation, such as resection of gangrenous intestine. Before the surgery, he administered an oral anesthetics potion, probably dissolved in wine, in order to induce a state of unconsciousness and partial neuromuscular blockade. Exact composition of mafezin, similar to all of Hao Tao's clinical knowledge, was lost when he burned his manuscripts just before his death. The composition of the anesthetics poured was not mentioned in either of records of three kingdoms or the book of the late Han. Because Confucian teaching regards the body as sacred, and surgery was considered a form of body mutilations. Surgery was strongly discouraged in ancient China. Because of this, despite Hao Tao's reported success with general anesthesia, the practice of surgery in ancient China ended with his death. Next sojourn is Hanaoka Seshu. Years of your life, 70, 60 to 80, 35. Hanaoka was a Japanese surgeon of the Edo period with a knowledge of the Chinese herbal medicine as well as Western surgical technique. He had learned through Rangaku, literally Dutch learning, and by extension Western learning. Hanaoka is said to have been the first to perform surgery using the general anesthesia. Алло. Я занят, попозже займемся. У меня лекция. Hanaoka was intrigued when he learned about the Hao Tao's mafezin potion. Beginning in about 7085, Hanaoka embarked on a quest to recreate a compound that would have pharmacologist properties similar to Hao Tao's mafezin. After years of research and experimentation, he finally developed a formula which he named Tsu-Sen-San, this formula, as known as Mafit-Tsu-San. Like that of Hao Tao, this compound was composed of extracts of several different plants. Today, we may suggest that the potion may have also contained hafish, blank, shang laf, or opium. Hanaoka's success in performing this painless operation soon became widely known, and patients began to arrive from all parts of Japan. Hanaoka went on to perform many operations using Tsatsen-san, including resection of malignant tumor, extraction of bladder stone, and extremity amputations. Before his death, 1835, Hanaoka performed more than 150 operations for breast cancer. He also devised and modified surgical instruments and trained and educated many students using his own philosophy from medical management. Hanaoka attracted many students, and his surgical techniques became known as the Hanaoka methods. Student, general anesthetics have been widely used in surgery since 1842 years, when Crawford Long administered diethyl ether to a patient and performed the first painless operation. In the slide, you can see the surgeon, Crawford Williams Long. Years of your life, from 1850 to 1878. And Crawford Long was an American surgeon and pharmacist, best known for his first use in inhaled sulfuric ether as an anesthetic. After observing the same physiological effects with diethyl ether, all simple ether, that Humphrey Davy has discovered for nitrous oxide in 1800. Yes, Long used ether for the first time of the 30 March 1842 years to remove a tumor from the neck of a patient. The name of this patient, James Venable. He administered sulfuric ether on a towel and simply had the patient inhale. They performed many other surgeries using this technique for the next few years, introducing the technique to her obstetrics practice as well. Long subsequently removed a second tumor from Venable and used ether as an anesthetic in amputation and childbirth. Despite his continued use of the ether anesthetics, Long did not immediately publish these findings. The results of these trials were eventually published in only 1849 years in the Southern Medical and Surgical Journal. An original copy of these publications is held in the USA National Library of Medicine. Nitro oxide. Next anesthetic is nitro oxide. Nitro oxide, commonly known as laughing gas or happy gas, was first discovered in 1793 years by the English scientist Joseph Priestley and has been used for more than 150 years. Next dentist is Haraswell. Years of your life, 1850, 15, from 1815 to 1848. Haraswell was an American dentist who pioneered the use of anesthesia in dentistry, specifically nitro oxide. Next surgeon, next dentist, William Thomas Green Morton. William Thomas Green Morton was an American dentist who first publicly demonstrated the use of inhalated ether as a surgical anesthetics in 1846 years. The promotion of his questionable claim to have been the discoverer of anesthesia became an obsession for the rest of his life. In the slide you can see the picture. The first anesthesia, the first use of ether as anesthetic in, I repeat, 1846 by Morton. On 16 October 1846, unaware of Long's prior work with the ether during the surgery, William Morton's administered ether anesthesia before a medical audience on the Massachusetts General Hospital in Boston. His work was published in December 1846 issue of Medical Examiner, which alerted Long to this other claim. Furthermore, the January 1847 issue of the editorial features more evidence and authorization experiments. Also, Long have informed several surgical colleagues who had similar administered ether in their practice and performed six additional surgeries since his initial discovery. Morton is generally credited with the first published demonstration of ether anesthesia. After these articles surfaced, Long began documenting in detail of his experiments, collecting patients' account and naturalizing they later. He reported his own findings to the Medical College on Georgia in 1849 years. Student, now I show you and tell about the history of intravenous anesthesia. Wren is a physiologist. Wren began intravenous anesthesia in 1656 years using the goose quill and a bladder to inject wine and ale into a dog's vein. Its experiments to dog. Invention of the hollow needle in 1843 years and the hypodermic syringe in 1853 allowed administration of drugs. By the 1900, device drugs, including ether, had been given for sedation. In this you can see the goose squeal, and at the first this goose squeal using as a needle for intravenous introduction. Student, now in this slide we can see the modern methods of intravenous infusion with helping the intravenous catheters. History of intravenous anesthesia. And this you can see the next drugs for anesthesia: hedonal, ether, paraldehyde, magnesia, and alcohol. In 1909, a Russian pharmacologist Nicholas Kravkov demonstrated the anesthetic property of hedonal in St. Petersburg. Hedonal was a urethane derivative used primarily to treat insomnia. It was the first agent given intravenously that produced surgical anesthesia with a moderate degree of safety. Unfortunately, hedonal dissolved minimally in water had a slow onset Андрюш, я лекцию читаю. Попозже, ладно? Ага, давай. Так. Unfortunately, hedonal dissolved minimally in water, had a slow onset and a long duration of hypnotic action. In 1909, Ludwig Barhart in Würzburg, Germany, discovered administration of ether and chloroform for surgical anesthesia. Subsequently, in 1911, Felix Roth in England gave 50% a solution of ether in saline intravenously to 18 patients, reporting that it enabled great flexibility of anesthetic depth and was accompanied by minimally postoperative vomiting or pulmonary irritation. In 1913, Noel and Sauter described the anesthetic effect of paraldehyde, and shortly after, Peake and Milson described the anesthetic effect of magnesium sulfate given by a continuous infusion. And Naragawa used ethyl alcohol for anesthesia in 1921, as did Cardot and Lauger in 1922. However, none of these anesthetics become popular in clinic practice. Now, student, barbiturate is a very widely used anesthetic, and at the first, Rodinat made the first barbiturate as called samnifin in 1920. With a sharp synthesized the short action hexabarbital in 1932. But the introduction of thiopental by Lude and Towel in 1934 provided the great advance dominating induction of anesthesia for the next half century. Price suggests in 1960 60 that thiopental redistribution from brain to muscular, rather than the fat, explained the rapid awakening from thiopental. This work underlie many subsequent pharmacokinetic and pharmacodynamic concepts. Thiopental decreases the cerebral metabolism and cerebral blood flow, leading to its use in 1970 to protect the brain from hypoxic insult. Metoxital, a short-acting barbiturate with central nervous system stimulating properties, was introduced in 1956 and remains a popular anesthetic for electroconvulsion therapy. Student, and now I tell you about the general anesthesia. And the general anesthesia bring about a reversible loss of consciousness and analgesia in order for a surgeon to operate on the patients. Their use is commonplace, but how they produce their effects is still not fully understood. A variety of drugs may be administered with the overall aim and ensuring unconsciousness, amnesia, analgesia, a loss of the reflex of the autonomic nervous system, and in some cases paralysis of the skeletal muscles. Classification of the type of anesthesia. All type of anesthesia are divided in general and local anesthesia. General and local anesthesia divided to regional anesthesia and local anesthesia. In this slide you can see general anesthesia and local anesthesia. The difference between these types of anesthesia is point of impact of anesthetics. In the first pictures you can see the general anesthesia and anesthetics. For general anesthesia, point of impact is the brain. It's brain. Receptors, central receptors of the brain. And local or regional anesthesia, the point of impact of anesthetics, it's nervous receptors, pain receptors on peripheral, and nervous trunks, as they called as a ring blocked. The point of impact general anesthesia is the brain receptors of the brain, and point of impact of local anesthesia is peripheral pain receptors and nervous trunk. Student, classification of general anesthesia. All types of anesthesia are divided into inhalational anesthesia and non-inhalational anesthesia. In this slide you can see the inhalational anesthesia, narcotic substance enter through the respiratory tracts, with helping the mask, with helping the endotracheal tube, and with helping with endobronchial tube. Non-inhalational anesthesia, narcotic substance is introduced by passing the respiratory tracts, and can be introduced intravenous method, intramuscular methods, and intraosseous method for introducing. Student, in the slide you can see the inhalational anesthesia, and now you can see the anesthesia machine. Breathing circuit, and tube for this apparatus. And you can see, fresh gas flow is determined by the vaporizer and flow meter setting. And you can see on this slide the inspired gas concentration of F1 is determined by fresh gas flow rate, breathing, circuit volume, and circuit absorption. And then alveolar gas concentration in here. In the slide you can see in here. Alveolar gas concentration is determined by uptake ventilations and concentrations effect and second gas effects. And then this narcotics gas introduced to arterial system, and then introduce the receptors of the brain. It's inhalational anesthesia. Student, now in this table you can see the anesthetics drugs who can use and now. And you can see the inhalational anesthetics, the first diethylator, and fluorine, methoxyfluorine, next halothane, isoflurane, desflurane, ceflurane, and student, diethylator and fluorine, all derivatives of fluorine, it's liquid anesthetics, but nitro oxides and xenon, it's gas anesthetic. In this you can see the chloroform. We did use in older time. Now we cannot use this chloroform. It's fluid anesthetic. It's the first surgeon can use this chloroform at the end of 19th century. Student, in this table you can see the drugs for intravenous anesthetics, properties of intravenous anesthetics agents. And this you can see the next anesthetics, thiopental sodium, etomidate, propofol, ketamine, midazolam. It's anesthetics agents for intravenous anesthesia. And in this you can see the properties of intravenous anesthetics agents. Difference between the intravenous anesthetics and inhalated anesthetics. Student, intravenous anesthetics specialized equipments and not necessary for they deliver all expensive facilities for the recovery and disposal of exhaled gas. And intravenous anesthetic and inhalated anesthetics, special equipments are necessary for the delivery. All expensive facilities are required for the recovery and disposal of exhaled gas. And other difference between the intravenous anesthetic and inhalation anesthetic you can see on this table. Student, in this slide you can see the anesthesia machine for inhalation anesthesia, and you can see the ways of introduce this anesthetics gas inside the lung. We can see the anesthetic machine in here and tube endobronchial tube for deliver this gas, anesthetic gas. In this you can see the anesthesia machine, and in here you can see the vaporizer for liquid anesthetics. And this you can see the monitor. Student, as you told you, the ways of deliver of inhalational anesthetics can be different. In the slide you can see the mask anesthesia with helping mask. On this slide you can see the endotracheal tube for deliver anesthetics inside the lung. It's intubation tube, and to the lung inhalational anesthetics. And this you can see the endobronchial anesthesia. When we can use the endobronchial tube, and this tube set on a lung bronch. Its method for inhalational anesthesia and the bronchial anesthesia we can use for surgery on the lung. Okay, and this you can see a device for total intravenous anesthesia for deliver intravenous anesthetics inside the venous. For the depth of anesthesia and the number of the drugs used, mononarcosis, to is all type of narcosis for the depth of anesthesia and the number of the drugs used. Mononarcosis, the use of single drugs throughout the operation. Next anesthesia, combinate anesthesia, the use of different narcotic drugs at a different stage of operations. And multi-component anesthesia, combination of different stage of the operation of various drugs and methods that have a purely specific effects. Muscular relaxation, controlled hypotension and hypothermia, allowing to reduce the amount of toxicity of narcotic drugs, blood loss and brain hypoxia. For use at different stage of operation, introductory anesthesia is used to ease sleep and eliminated unpleasant sensation. And supporting anesthesia, main anesthesia, introductory anesthesia is the time of the start, the surgery, and then we can use supporting the main anesthesia during the whole operation. It's different depending on the time of this anesthesia. Student, in next slide you can see the stage anesthesia and clinical signs of this stage. General anesthesia have the 4 stage of anesthesia. The first stage of analgesia and disorientation. Beginning from induction of general anesthesia to loss of consciousness. It's time from beginning of induction of general anesthesia to loss of consciousness. Stage number 2, stage of excitement and delirium. Beginning from the loss of consciousness to onset of automatic breathing, and eyelash reflex disappeared, but other reflexes remain intact or coaching. Vomiting and struggling may occur. Respiration can be irregular with breath holding. The stage number 3, duration from one set of automatic respiration to respiratory paralysis. It is divided into 4 planes. Stage 3 divided into 4 planes. And now I explain these planes. The planes number 1, from one set of automatic respiration to cessations of air ball movements. And air reflex is lost. Swallowing reflex disappears. Market airballs movement may occur, but conjunctival reflex is lost, and the bottom of the plane. The plane number 2, from cessation of able movements to beginning of paralysis of intercostal muscular. Laryngeal reflex is lost. LSAT inflammation of the upper respiratory tract increase reflex irritability. And corneal reflex disappears. Secretion of the tears increases. A useful signs of light anesthesia. Respiration is automatic or regular. Movement and deep breathing as a response to skin stimulation disappears. Student, plane number 2, it's time for surgery. It's time for surgery. Plane number 3, from beginning to complication of intercostal muscular paralysis and diaphragmatic respiration persists, but there is progressive intercostal paralysis. Pupils delayed and light reflex is abolished. The laryngeal reflex lost a plane 2 can still be initial by painful stimuli arising from the dilatation and anus of cervix. This was the desired plane for surgery when muscles relaxant were not used. And plane number 4, for complete intercostal paralysis to diaphragmatic paralysis, apnoea. And stage number 4, from stoppage of respiration till this. Anesthetic overdose caused medullary paralysis with respiratory arrest and vasomotor collapse. Pupils are widely dilated and muscular are relaxed. Student, from the 3 plane of stage number 3 to stage number 4, it's overdose of anesthetics, and we can use only stage 3 plane 2 for surgery. Next slide. 2 is the difference between the 2 groups of anesthesia, and in this you can see the general anesthesia. Anesthetics acts on the receptors of the brain. Delivery technique inhalational, intravenous, intramuscular technique. And systemic effects of general anesthesia: cardiac activity, respiration, muscular relaxation, metabolism, and thermoregulator centers. General anesthesia affects to this. Regional anesthesia. Anesthetics acts on peripheral pain receptors, nervous plexus, and spinal cord. Delivery technique, topical anesthesia, infiltrative anesthesia, ring block, and peripheral nervous block. And systemic effects, almost absence systemic effects. Student, next type of anesthesia is regional anesthesia. Regional anesthesia and other local anesthesia. Regional anesthesia affects on the body to a lesser extent. Local anesthetics are safer than general or systemic anesthetics. Therefore, they are used whenever possible. In addition, they are relatively easy to administer and readily available. Local anesthetics have been undergoing development for centuries, and research continues to provide surgeons with pharmacologist variety and to provide patients with anesthetics agents that have superior safety and efficacy profiles. Regional anesthesia and local anesthesia. It's the same, but this type of anesthesia, regional anesthesia and local anesthesia, have a little bit difference. Regional anesthesia, large part of the body, such as the limb or the lower half of the body, and local anesthesia for a small part of the body, such as the thoughts, or an area of the skin. In the slide, you can see the Sigmund Freud. A local anesthesia in surgery have started to apply later of general anesthesia. In 1860, and can use the cocaine. At the first, can use the cocaine. The oldest anesthetics was extracted for leaves of the erythroxylon coca. In 1884, Sigmund Freud and Karl Koller were the first to use it as an anesthetic agent during ophthalmological procedures. And this you can see the next, the modern anesthetics, procaine synthetic alternative to cocaine, was not developed until the 1904. Procaine is ester of para-aminobenzoic acid, as procaine is metabolized. Unknown allergen is released metabolic product. It's to procaine, it's to original anesthetics, and now we can use this procaine. And on this, in the first picture, you can see the procaine, and the second picture, you can see the tetracaine hydrochloride. In 1943, an alternative class of anesthetics was discovered when the Lockyer developed lidocaine. This agent is aimed derivative of diethyl aminoacetic acid. Therefore, it has a benefit of a low allergic potential. Since then, multiple A-type anesthetics have been introduced into clinic use. A slight chemical alteration to the compounds have improved beneficial characteristics, including increased duration of potential to each. These compounds offer the surgeon more choice, and anesthetics can be appropriately matched to different procedures. In the slide, you can see this lidocaine. Lidocaine we can use in modern time. It's very widely. Next, regional anesthetics is ultracaine. Ultracaine, it's better anesthetic for regional and local anesthesia. Student, in this table, you can see the local and regional anesthetics. And the first anesthetic, lidocaine. Second anesthetic, mepivacaine. Next anesthetic, tetracaine, ropivacaine, and bupivacaine. All these anesthetics we can use for regional and local anesthesia. Student, local anesthesia can be divided some groups, and these groups of local anesthesia, the first, the topical anesthesia, we can use the spraying and air drops. Infiltrative anesthesia. Next, local or regional anesthesia, ring blocks, and peripheral nerve blocks. And now I show you this type of anesthesia. We have this topical anesthesia. With spraying the 10% of lidocaine. It's local anesthesia for surgery on the mouth cavity. Student, in this slide you can see the infiltration anesthesia. It's local anesthesia, infiltration anesthesia, and this stage of this anesthesia Алло. Попозже, у меня лекция, попозже. In the slide you can see the introduce with helping the needle, this anesthetic, and in this slide you can see the start of infiltration anesthesia. The first layer is performed infiltration in the form of a lemon crust, and this you can see the lemon crust in here. It's right. Introduce the anesthetics, and next the second layer is performed infiltration of subcutaneous adipose tissue. Depots we make the lemon crust, and next we introduce this anesthetic drugs subcutaneous tissue. And then the third layer is performed infiltration muscle and deeper tissue. Muscle and deeper tissue. Student, in this slide you can see the neurostrung for regional anesthesia. If you can use the block of neurostrungs, no, for example, in this plexus of the leg, this plexus of the hand, when we ring block it, this patient, all hands, all legs have painless. In this slide, you can see the regional anesthesia. This ring blocks this nerves. Так, wait 1 minute. Okay. And next slide, you can see the ring blocks of ulnar nervus. Ulnar nervus, and all hands of this patient painless after these blocks. In here, you can see the blocked nerves of medians nerves, blocked, with helping the lidocaine, It's point of the median nerves, it's blocking of these nerves. Student, close the door. Close the door. No, close the door. Student, in this slide you can see the anesthesia Oberst Lukashevich anesthesia. When the anesthetic introduces the soft tissue of the finger. We can see the tourniquet in here, and upper the tourniquet introduce the anesthetics in soft tissue. This anesthesia called as a Oberst Lukashevich anesthesia. In this slide, you can see the drop A anesthesia for ophthalmological surgery. Так, student, and next type of anesthesia, it's a spinal anesthesia. When the anesthetics introduce the spinal cord. And this you can see the spinal anesthesia. Spinal anesthesia have been used since the late 19th century to numb the lower half of the body for surgery. Cocaine was the first local anesthetics used in spinal anesthesia. But cocaine toxicity causes a lot of unwanted side effects and complications. Today we can use lidocaine. Bupivacaine and ropivacaine are among the most common agents used. The technique, medication, and needles have evolved over time, but there are still some post-spinal anesthesia side effects then can occur. Knowing that most of these are minor and temporary can provide peace of the mind before the after your surgery with spinal anesthesia. And on the picture you can see the level of introduced anesthetic drugs. Area of injection in here. It's lumbal vertebra. 1, 2, 3, 4, 5. Lumbal vertebra, and this point for introduce anesthetics. Okay, in this photo for spinal injection. Level for spinal injection L4, L5. And this you can see the spinal injection. Okay, student, it's the finish of our lectures and goodbye.